Welcome back to this next video in which we are discussing coronary artery disease. Okay, so we're currently in the process of trying to explain why, in the case of a transmural myocardial infarction where the full wall thickness of the myocardium has undergone the necrosis process, has died, then if you look at leads in the 12-lead ECG, which have the 2 points over the portion of the myocardial wall that has actually undergone the infarction, then you will see an ST elevation. You'll see the ECG looking like this general pattern instead of the normal pattern, i.e. you won't have a S wave here, and instead the ST segment will be elevated up, and then you'll go into the T wave like so, i.e. why on those leads of the 12-lead ECG a transmural infarction looks like an ST elevation myocardial infarction, and why therefore we use these two terms interchangeably. Then we're also trying to understand, of course, why in the case of just a subendocardial myocardial infarction, why when you look at the leads in the 12-lead ECG which have the 2 point over the portion of myocardium that has undergone infarction, in that case you don't see ST elevation and the ECG will look more close to the normal thing, okay, i.e. you will have an S wave and a non-elevated ST segment. Okay, right, so we've spent some time going over the sort of prerequisite understanding of where the ECG pattern usually comes from, and now let's actually begin to explain why when we have a transmural infarct and we look at these leads which have the 2 point over the portion of myocardium that has undergone the infarction, we're actually going to see ST elevation in the ECG pattern. Okay, so there are 2 reasons for why, well actually the first thing I should say is it's still a little bit controversial exactly why this happens, but overall most people believe there are 2 reasons for why you see the ST segment rising, and we can split these 2 reasons into the fact that there's going to be a systolic current and there's also going to be a diastolic current. So the explanation for the ST elevation comes in 2 parts. One we will title the systolic current, and the other we will entitle the diastolic current. And these currents are the currents that are going to show up on the ECG. They're currents that are going to be created within the heart due to this portion of infarcting myocardium that will change the appearance of the ECG and will result in this appearance of ST elevation. So we're going to try and understand the systolic current and the diastolic current, and we'll start off by talking about the systolic current. Now, to understand systolic and diastolic current, we need to know something about what happens in cardiomyocytes whilst they're undergoing the infarction process, because you're going to see this ST elevation in the leads of the 12-lead ECG where the 2 point is over the portion of myocardium that is undergoing the infarction process whilst it's actually happening. Once it's actually happened, then you're not going to see the ST elevation anymore. It's only whilst it's happening, and it has to do with the change in the behaviour of the cardiac action potential in the cardiomyocytes that are becoming more and more ischemic as they're approaching dying. Okay, so remember I told you the timeline for a myocardial infarction. From the instant that the thrombus forms in the coronary artery, you're going to start getting ischemia downstream, and the cardiomyocytes are going to start becoming ischemic. They're going to turn on anaerobic respiration, and that will lead to a lactic acidosis. And then after about half an hour, they start to actually get such a bad lactic acidosis that it's going to result in actual cell death. It's going to result in necrosis. Okay, really, the window for seeing the ST elevation is whilst you've still got some cardiomyocytes that are not completely dead yet, but then misfunctioning. They're behaving oddly because of the lactic acidosis, and it's this odd behaviour in those cardiomyocytes that are extremely ischemic that is going to create this ST elevation in the ECG pattern in the case of a transmural infarction, and not so in the case of a subendocardial infarction. Okay, so what I need to explain to you then is how these myocardiocytes that are yet to die, they're not dead yet, but they're going towards the dying process. They're undergoing lactic acidosis and they're starting to behave oddly. What's going to happen is their cardiac action potential is going to change. So let me just draw a cardiomyocyte here. In addition, let me just draw out the normal cardiac action potential. So if this cardiomyocyte is conducting an action potential along its cell membrane, then of course what you can ask is, what's the electrical potential difference across the cell membrane at a certain point on the cell membrane, and you can plot this against time, and you get that classical pattern. And I just want to remind you of this classical pattern and show you how this classical pattern is going to be disturbed in these cardiomyocytes that are being exposed to the ischemia and are heading towards dying, heading towards infarction. Okay, so I'm not going to explain the cardiac action potential pattern. I'm assuming that you have seen that explanation before. I'm just going to remind you of what it looks like. So normally the electrical potential difference across the cell membrane of a cardiomyocyte starts off at around negative 80 millivolts, and then what happens is when the cardiomyocyte gets stimulated, or when a piece of cell membrane gets stimulated to undergo the action potential, you're going to get depolarization of the electrical potential difference up to the threshold potential for the opening of the voltage-gated sodium channels, which is around negative 40 millivolts. So here is the depolarization. Then when the voltage-gated sodium channels open, they will allow further depolarizing current from the extracellular fluid into the inside of the cell, and this will depolarize the electrical potential difference across the cell membrane up to about plus 20 millivolts. Then what will happen is the voltage-gated sodium channels will inactivate, and just about when the voltage-gated sodium channels start to inactivate, you get some voltage-gated potassium channels opening. Now remember, there are loads of different types of voltage-gated potassium channels. They are usually activated to open again when the electrical potential difference across the cell membrane depolarizes to negative 40 millivolts. That's the threshold potential for most voltage-gated ion channels opening. It's just that the voltage-gated potassium channels, unlike the voltage-gated sodium channels, are much slower about opening. So the voltage-gated sodium channels, they get activated to open and open incredibly quickly, which is why you instantly get this sodium current coming in. The voltage-gated potassium channels, they're much more slow in opening, and they only start to open at the time that the voltage-gated sodium channels have been and done that. They've opened and now inactivated. So you start to get some voltage-gated potassium channels opening, allowing a potassium current to leave. This causes the rapid repolarization phase. Okay. Then what's going to happen is the voltage-gated calcium channels, L-type voltage-gated calcium channels, are going to open again. They were activated to open back at negative 40 millivolts, but they're much slower to open as well. They're going to allow calcium into the cytoplasm of the cell. This will balance the small potassium current that you've got going out of the cell, and you'll get a no change portion of the electrical potential difference across the cell membrane, known as the plateau phase, where the calcium current in balances the potassium current out. Then the L-type voltage-gated calcium channels will start to inactivate, and more voltage-gated potassium channels will start to open. So voltage-gated potassium channels, the majority of them take absolutely ages to open, and they're starting to open here. Okay, there were some really early ones. Remember, if you've ever studied voltage-gated potassium channels, you'll know there is an absolute plethora of different voltage-gated potassium channels, and it's different types that are responsible for opening here than opening here. So most of them end up opening right down here, and then you get the repolarization phase back down to below the threshold potential here, and then it takes it back down to negative 80 millivolts, and then the voltage-gated potassium channels will start to close, of course, because we're back below the threshold potential for them being open. Okay, so that's the classical form that the cardiac action potential takes. Okay, now what I want to do, I'm just going to colour that in. This is a healthy cardiomyocyte action potential. And remember what this is showing. It's showing the electrical potential difference across a single little patch of membrane. Now what I'm going to do, and of course this will propagate this disturbance, this pattern in the disturbance of the electrical potential difference across the cell membrane. It propagates from portion of membrane to portion of membrane to portion of membrane to portion of membrane by saltatory conduction. Okay, and when it reaches the end of the cardiomyocyte, it will then propagate through the gap junctions to the next cardiomyocyte along. Okay, now this action potential, the form of this action potential changes in these cardiomyocytes that are exposed to ischemia so bad that they're going to start infarcting, and it's prior to them actually dying, because we know that when they die, their cell membranes, you know, they lose the integrity of their cell membranes, and they're not going to be able to conduct action potentials at all at that point. But prior to them actually beginning the dying process, cardiomyocytes are still capable of conducting action potentials, but their electrophysiological properties are going to change because of the lactic acidosis, and the reasons for these changes aren't particularly well understood, but this is what does happen. Firstly, they have a permanently elevated electrical potential difference across the cell membrane. So their electrical potential difference, that is the resting one, goes up. It moves up from negative 80 millivolts to something higher, maybe negative 60 millivolts, like so. Then when they actually are induced to fire an action potential, when the cell membrane is induced to undergo the action potential, then same as before, they will depolarize to negative 40 millivolts, and then the voltage-gated sodium channels will depolarize them, but they never get as high up as you do in the normal cardiac action potential. So you just don't depolarize to the same level. The pattern is the same, but everything's just below the normal one. So this is the sort of pattern in these disturbed cardiomyocytes. This is what the action potential looks like. It's like a you know, the healthy one, but sort of crushed down a bit. So you elevate the resting electrical potential difference up, and then you lower down all of the extremes that you can get to in the action potential. So these ischemic cardiomyocytes in the myocardium that have not got their correct blood supply coming to them because of the acute coronary event, this is what their action potential short term is going to go over to. So in this portion of myocardium that is going to undergo coagulative necrosis because of the ischemia, this is what the action potentials in those cardiomyocytes are going to look at. So if you were to look at the ECG of someone having an acute coronary syndrome and they were going to suffer from a transmural myocardial infarction because they've got a complete occlusion of one of their coronary arteries, then the fact that the cardiomyocytes in that region have changed their action potentials temporarily to this is actually going to lead to the disruptions in the ECG, or is believed to underlie the disruptions in the ECG that are going to cause the STEMI. Okay, and the reason that it's going to cause the ST elevation of the ECG pattern is because it's going to create systolic currents and diastolic currents. So let me firstly explain systolic currents. Okay, so if we think about the ECG pattern, so let's say we have a lead where the 2 electrode is over the portion of ischemic myocardium. So here, and let's go back to this picture up here, and I'll just move it down so it's right in the center. Okay, so here, let's say this is the portion of myocardium. We're going to have a transmural infarct, and all of this is going to go. Let's say that we have picked a lead of the 12-lead ECG where the 2 point is nicely over the portion of the myocardial wall that is actually undergoing the ischemia. And by the way, something that I didn't dwell on in the previous video, but which is really important, is the fact that by looking at which leads of the 12-lead ECG actually show the ST elevation, you can work out where the actual infarction is going to occur, so which portion of the myocardium is actually going to be affected by the ischemia. Okay, and that's one of the uses of the 12-lead ECG, that you can work out roughly where the portion of ischemia actually is. Okay, so let's now think about what's going to actually happen electrically. Okay, so thinking specifically about the ST portion. Okay, so remember, these cardiomyocytes have not yet died. They're still they're still conducting electrical signals, just strange electrical signals. They are undergoing these action potentials here. Okay, so if we think about ventricular depolarization, that's the QRS complex here. So what's going to happen is the electrical signal is going to come down the bundle of His here, down the right and left bundle branch. It's still going to be released on the interventricular septum, so you'll still get the nice little Q wave here as the electrical current, the cardiac vector, goes in that direction. You know, even if we're looking at even if we're looking at a lead like so, you can imagine that the component of that vector, it's going like so. So you're going to get a downward deflection in this case. This ECG pattern for from here to here would look very similar to lead 2, just a slightly less extreme version of it potentially. Then what you'll get is major ventricular depolarization, and still what will happen is the electrical signal will propagate out from the subendocardial to the subepicardial. So that's absolutely fine. So you'll get the R wave here. Okay. Now let's think about why you're actually going to get this ST elevation. The S wave will still be there, but it's just not going to be visible on top of the ST elevation here. You might see a little sort of dip down like so, but it's not going to be back down here. Okay, because you are still getting the electrical signal propagating up the posterior portions, it's going to be not visible in the ECG pattern because something else is happening that's covering it up. So why are we now getting this ST elevation here? Okay, well, if you think about what's going to happen, when usually in the ST segment here, that's when the cardiomyocytes of the ventricular wall are in the plateau phase of their action potential, and usually they're all in the plateau phase together, and therefore you're not getting any currents occurring between the cardiomyocytes because they're all in the plateau phase. The electrical potential in the intracellular compartments of all the cardiomyocytes is the same, so you haven't got any currents, and therefore you haven't got any deflection of the ECG. It goes down to the isoelectric line. However, if we've got all of these ventricular cardiomyocytes here behaving in this odd way, where their plateau phase has electrical potential difference across the cell membrane much lower than here, then that's going to mean that the electrical potential in the intracellular compartments of the cardiomyocytes here during plateau phase is going to be lower than the electrical potential in the intracellular compartment of the cardiomyocytes elsewhere in the ventricle. And the idea then is that that's going to cause positively charged ions to move from the intracellular compartments of the surrounding cardiomyocytes, so of all of the ventricular cardiomyocytes here, into the ones that are undergoing the ischemia. So you're going to get a positive current towards the place where you have this ischemic myocardium because of the fact that the plateau phase here, the electrical potential difference across the cell membranes is so much lower, and that one of the reasons for that is that the electrical potential intracellularly is going to be much lower than it would be in a normal cardiomyocyte. So if you think about this, if we've got two cardiomyocytes here, so let's say one of these is normal, and I'll just have this one coloured in blue. So let's say this cardiomyocyte is normal, and let's say this cardiomyocyte in green here is the abnormal one. Okay, so if we think about the abnormal one now, its upstroke of the action potential doesn't get as high. Now that means that not as much sodium is coming in. So if not as much sodium is coming in, then that's not going to raise the electrical potential in the intracellular compartment of this cardiomyocyte anywhere near as much as it would in the normal one during the upstroke. So this one's electrical potential intracellularly, the damaged one in the action potential in the plateau phase here, will not be as high as it is in the normal one in the plateau phase, and that's going to create an electrical potential difference between the intracellular compartments of these cardiomyocytes. Namely, positively charged ions are going to want to move from the normal ones to the ischemic ones. So now, even in the plateau phase, we are going to have electrical potential differences between the intracellular compartments of cardiomyocytes, and that's going to create as a positive current towards the area of ischemia here. Okay, and of course, a positive current in that direction is going to be seen by a positive deflection of the ECG trace like so, which is why the ST segment is going to appear elevated. So that's the systolic currents, okay, because they're occurring during the systole, ventricular systole, because of course in the plateau phase of the action potential, that's when the ventricles are actually, well, the ventricular cardiomyocytes are actually contracting. So this is the systolic current resulting in this elevation of the ST segment here, but there's another current that we also think contributes to the appearance of the ST elevation, and I'll explain that in just a moment. But just to summarize then with the systolic current, so because these cardiomyocytes in the ischemic portion, their action potentials are altered and they have less sodium ions coming in during the upstroke of their action potentials, then the electrical potential in their intracellular compartments during the plateau phase of their action potential is not going to be as high, as elevated as it is in the normal cardiomyocytes. Okay, that creates an abnormal electrical potential difference, favouring the movement of positively charged ions from the surrounding cardiomyocytes to these ones. And you can imagine that if the surrounding ones then pass current onto these ones, they've lost positive charge. So now there's a electrical potential difference gradient between them and their neighbours, so positive charge will come from their neighbours into them, etc. It caused a chain reaction of positive charge overall moving in this direction, and that creates a cardiac vector that's going to be in this direction throughout the plateau phase, hence why we would see an upward deflection of the ECG pattern. And that current, that new cardiac vector that's occurring in the heart towards the area of ischemic myocardium, that's known as a systolic current. Okay, right. Now let's move on to the diastolic current explanation of the ST segment, and it's probably, there is still, as I say, a lot of controversy as to the explanation of why the ST segment appears elevated on an ECG trace for someone who is suffering from a transmural myocardial infarction. Some people very heavily just believe in the systolic current theory of the ST elevation myocardial infarction, while some people very strongly just believe in the diastolic current theory, whereas the probable truth that most sensible people accept is that it's probably a component of both of them, and that's the account of this that I'm giving you. Okay, so I'm going to say that the ST segment elevates probably because of a combination of both of these. So the systolic current, we now understand why that is going to lead to elevation of this ST segment of the ECG. Diastolic current, the idea here is that it's not that, well, the idea here is that what you're going to do is bring down this portion in the diastolic portion of the ECG, which is the portion after contraction. Okay, so remember systole and diastole. Systole means ventricular contraction. It means that the portion where the ventricles are actually contracting. Diastole means the portion where the ventricles are relaxing. Everything's done in terms of the ventricles. Okay, so even when we've got atrial systole here, that's not counted as overall systole in the heart. So all of this portion here, from here to here, this is the sort of systolic portion of the ECG, whereas this portion from here all the way through the P wave and through this portion between the P wave and the beginning of the QRS complex, they're called the diastolic portions. And the idea is that in the diastolic portions, what you're going to have is a current also that's going to be moving in the opposite direction, i.e. away from the ischemic myocardium to the rest of the ventricles, and that this is going to cause downward deflection of all of these. So you can imagine moving all of these down a little bit. It's best shown here, but imagine moving that down as well. Okay, and if you can imagine bringing this down, if you bring this portion down like so, you can see that what this is going to do is it's firstly going to make the T wave look more extreme, which is another more minor feature that you see on these ECGs of people suffering from transmural myocardial infarctions. In addition, the way it works when you're looking at an ECG, we just call this portion, this flat line in between each cardiac cycle, we call that the isoelectric line. Okay, so the isoelectric line, we don't actually know that that really is the point where we have no electrical potential difference between the 2 points that we're measuring between. Okay, we just take it as this flat line and we assume that that is the point where we have no electrical potential difference between the 2 points, but we don't actually know that there is zero electrical potential difference between the 2 electrodes at that point. Okay, the ECG trace doesn't actually give us the numbers, it just gives us the changes. Okay, so when this all appears lower, we call this point the isoelectric line, even though it might be the case that there is actually a negative electrical potential difference between the electrodes. But just due to technical limitations, we don't know that, and we just call this the isoelectric line, assume that this is the point where there is zero electrical potential difference. But you can see that what that would mean us interpreting is relative to what we're calling the isoelectric line, which might not actually be anymore truly the point where there is no electrical potential difference between the 2 points. Relative to that, this is now going to appear even more elevated. Okay, and this is the concept that in the diastolic period we've moved everything down, and that's also going to contribute to therefore the ST segment appearing elevated above what we are calling the isoelectric line, which is just this flat line in between concurrent cardiac cycles. So let me now explain why in the diastolic period then we think that there could be a downward deflection from the true isoelectric line, which we can't actually see. That isn't drawn on the ECG. We can't actually see that. Okay, but you can imagine that there would be a true isoelectric line where there is zero electrical potential difference between the 2 points. Okay, it's just that when you're actually looking at an ECG trace, it doesn't show you that. Okay, you just look at this flat line here and say that's the isoelectric line, but you don't actually know that. Okay, so it could be that what we are calling the isoelectric line in the diastolic portion of the ECG trace isn't actually an isoelectric point where you've got zero electrical potential difference between the 2 points, because there might be diastolic currents. And let me now explain the nature of diastolic currents. So, in this portion of ischemic myocardium, I've shown you that the electrical potential difference at rest, i.e. in the diastolic period of the cardiac cycle, is actually going to be elevated in the ischemic myocardial compared to the normal ones. That means that the intracellular electrical potential is going to be higher in the ischemic ones compared to the ones that are normal. Okay, so that means that there's going to be an electrical potential difference between these two intracellular compartments, favouring the movement of current, positively charged current, from the unhealthy ones to the ones that are normal, i.e. away from this transmural infarct here. So now you're going to have the cardiac vector pointing in the opposite direction, spreading from this area towards this point. Okay, and that's going to be going on throughout the entire relaxation period of the ventricles. You're going to be getting current moving away from the ischemic portion towards the ventricles, and this would therefore lead to a continuous downward deflection of this. So imagine moving all of the PR intervals well downwards a little portion. Okay, and that, you can imagine, would also lead to the ST segment appearing elevated. That is known as the concept of diastolic currents, currents that are moving in diastole away from this portion of ischemic myocardium into the remainder of the myocardium that is not ischemic. Okay, so that then is my attempt to explain to you, and I hope I have explained to you, I hope you do understand why, if you've got a transmural infarct and you look at the leads where the 2 point of the lead is over that portion of the wall that has actually become ischemic, then you will actually see this ST elevation in the ECG trace. Okay, there are these two explanations, the systolic currents and the diastolic currents, which arise due to the changes in the electrical activity of the cardiomyocytes that have been exposed to this ischemia. Now note, once all of the cardiomyocytes here have died, of course this will stop. Okay, once they're no longer conducting action potentials at all, all of this will stop after that. Okay, but whilst they're still in the process of just being damaged and then moving towards dying, and of course at this point you'll have the horrendous pain, so you'll know that you've got something incredibly wrong, so you might have rushed to hospital, they might now have put you on an ECG machine, this is what you might actually see. Okay, and this can be used to decide whether the area of ischemia is transmural, and also where it actually is in the myocardium. Okay, although later on we'll talk about another investigation for working out more precisely which portion of the myocardium is ischemic, but this is one thing that clinicians can use to gain insight into which portion of the myocardium is actually ischemic. Now, why then does this not occur if you've just got a subendocardial myocardial infarction? Okay, so let me imagine taking this black portion out here and now replace that in the drawing with this, okay, where we've just got a subendocardial portion that is actually ischemic. The subepicardial portion is fine. Okay, it's just the subendocardial portion now that's ischemic. So chop this bit out of the picture and put that in. Now let's think about why you're not going to get systolic currents and why you're not going to get diastolic currents. So let's start with systolic currents. So the story is exactly the same. The ischemic cardiomyocytes are going to have these altered action potentials, and that's going to create the desire for positively charged ions to move in the plateau phase of the action potential from the normal cardiomyocytes to the ones that are ischemic. But this time, think about how it's going to work. Not only are you going to get current moving from all of the surrounding cardiomyocytes to these ones that are ischemic, but you're also going to get current moving from these ones that are normal into the ones that are ischemic. I.e., you're going to get current moving from here to here. but you're also going to get current moving from all of the surrounding cardiomyocytes, and the cardiac vector for that is in this direction. Can you understand, with basic maths here, or well, not maths, that'll just confuse people, but basic intuition here, that those two currents now could potentially cancel each other out, and overall, therefore, if we're looking at the electrical potential difference between these 2 points, are we actually going to notice any difference? Well, if we've got a sort of equal amount of current moving in that direction and a sort of equal amount of current moving in that direction, those are going to cancel each other out, and you're not going to see any changes in the electrical potentials of these 2 points, and therefore you're not going to see any change on the ECG. So because of the fact that you have this subepicardial myocardium over the subendocardial myocardium that will also have currents moving from it to the ischemic myocardium during the plateau phase, that's going to cancel out the movement from the surrounding ventricular cardiomyocytes and mean that it's not going to actually be seen on the ECG. So you still do have systolic currents in this way, it's just that they're not going to actually be seen because you've got them going in both directions, and you only see it on the ECG when you've overall got a net movement in a certain direction in line with the vector of the lead that you're looking at. Okay, so that's why the systolic currents go out the window. Let's now talk about the diastolic currents. Why are we not going to see diastolic currents? Well, same thing again. The subendocardial myocardial cells that have undergone the ischemia, or that are being subjected to the ischemia, they will have permanently elevated electrical potential differences at the resting state. Okay, so the electrical potential inside them intracellularly during the resting state is going to be above that in the normal cardiomyocytes. So again, you've got the temptation for positive charge to move from the ones that are ischemic to the normal ones. Okay, but this time you've got to remember that there are these normal ones above them in the subepicardial region. So not only this time are you going to get current positive charge moving out like this, i.e. in this direction to the surrounding portions of myocardium that aren't ischemic, but you're also now going to get current moving from the ischemic portion here to the subepicardial portion, and that the vector for that will be opposite to the vector for it spreading to these portions. And again, you can imagine that that would cancel out so that it wouldn't actually result in an electrical potential difference or alteration between these 2 points. Okay, and that's why, even though you still do have diastolic currents, overall you don't have a net diastolic current that is going to therefore result in a change in the electrical potential difference between these 2 electrodes, and therefore would show up on our ECG. Okay, so that is the explanation for why then, when you've got just a subendocardial myocardial infarction due to one of these thrombi that hasn't completely occluded the blood vessel, has obviously hugely damaged blood flow for it, but you're getting enough blood to the subepicardial myocardium, it's just the subendocardial myocardium that's got the problem. Okay, why then, when you look at the ECG of someone presenting in hospital with that, with the pain of course due to that, and you go to the leads over the ischemic portion of myocardium, you're not actually going to see the ST elevation, and the ECG for this type of myocardial infarction will look more normal, so it's therefore called a non-ST elevation myocardial infarction, or an NSTEMI. Okay, so that concludes then my explanation as to why subendocardial myocardial infarctions on the ECG, they look like non-ST elevation myocardial infarction, i.e. we call them NSTEMIs, and why with a transmural infarct you do get that ST elevation on the ECG trace, and why we therefore call them STEMIs, ST elevation myocardial infarction. Okay, we will move away from this now, and in the next video what we will do is go on to the treatment of angina and myocardial infarction. We'll begin by talking about ways that you can investigate coronary artery disease. In particular, we'll talk about coronary angiograms, and then what we'll talk about is all the different treatments that we can do for someone who is suffering from stable angina, because a big part of treating coronary artery disease is taking people who have stable angina and trying to do something to prevent it actually resulting in an acute coronary syndrome. We want to prevent people having heart attacks because of the fact that they can cause sudden death, and then if you do survive them, they can cause those horrible long-term complications of arrhythmias and heart failure. Okay, so we'll go through that in the next video.